Okay. Good afternoon, everyone. I'm not sure if you can see me or not, but for those of you who don't know me, I'm Dave Steele. I'm coordinating this month's roundtables, and I'm delighted to introduce Dr. Adrienne Kania from the Burrell College of Osteopathic Medicine. Dr. Kania has 25 years of practice experience in internal medicine and osteopathic manipulative medicine. She'll be telling us about that. She is one of the founding faculty members at the Burrell College and is head of the Department of Osteopathic Manipulative Medicine. And as someone who in my previous career was involved in getting new medical schools started, I can attest to the fact that that is an exciting pathway to be on. But for those of you who know me, I used to be 6 feet tall and I've been whittled down to size. So welcome, and we'll turn the floor over to you.
Thank you so much. Yes, those of us who start new schools, it makes you kind of wonder, are we just incredibly idealistic or naive? I'm not quite sure. This is my second startup, so
wow.
I guess I didn't learn from the first, or I learned a lot. Actually, the way I'd like to do this presentation, because I don't really know my audience here, David had mentioned that he would like me to talk a little bit about osteopathic medicine under the assumption that some of you may not know what that is. And then also to talk about the impact that Burrell has had on the Las Cruces area. Please interrupt me at any time. Let's keep this really informal because it's supposed to be a roundtable discussion, not a lecture. And so I'd welcome questions at any point. Do we have any to begin with? All right. So then if, Michaela, if you could put the PowerPoint back up. All right, and you can go ahead to the first slide or pass the titles, or actually go on to the next. So the first question I'm going to address is, what is osteopathic medicine? It's really a different philosophy than what we refer to as allopathic medicine, or what MD doctors, medical doctors think of. And this is all based on the experiences that the founder, Andrew Taylor Still, who was an MD back in the 1800s, had when he was caring for patients. And, at that time, he recognized that those people who chose not to go to the doctor actually tended to do better than those who went to the doctor, mainly because a lot of their therapies were downright dangerous, considering that they were using arsenic and mercury as some of their therapeutics, or bloodletting too, which doesn't make sense in retrospect. So some of his philosophies was that health is a natural state of harmony, and that as long as we have good blood flow, good nervous flow or nervous activity, then everything should be working in harmony. And that when we see disease, it's really because there's disharmony in the system. And sometimes that disharmony is caused by mechanical impediments to the normal flow of fluids, like blood, lymphatic fluid, exoplasmic flow through nerves. But by the same token, all of us have had the situation where we worried ourselves into a headache or an upset stomach. And so stress, whether it's internal or environmental or social, certainly plays an impact on our well-being. And I would imagine that many of you also are aware that adverse childhood events are probably the largest predictor of illness in people beyond anything else. And so if we can start handling our stress, then maybe, or addressing it at a societal level, we could all actually achieve better health. And so this is kind of our philosophy, that we're coming at this from a bigger picture, not just treating the disease that's there. I'll take the next slide, please. So we have 4 tenets, and you're going to see these written in multiple ways in the next few slides. And basically, doctors still believe that the human body provides all the chemicals necessary for the needs of its tissues and organs. And it seems the more we learn about the body, the more this is actually true. We also know that there's a relationship between the structure and the function of the human body. And again, if we have a mechanical impediment, that's going to impair the function of organs or the musculoskeletal system. And ultimately, we want to come up with a management program or plan that meets the needs of an individual patient, but it should also be based on what we understand of the previous things listed. So next slide, please. So the 4 tenets are actually written in the top circles, and the bottom ones actually are how we try to bring the thought into patient care. And so if a person is a product of their an interaction between mind, body, spirit, then we really need to be looking at the autonomy of a patient, but also their spiritual well-being as well as their physical well-being. And I'm not going to say that any of these concepts are uniquely or unique only to osteopathy. A lot of other approaches are. But when Dr. Still brought this out in the late 1800s, this was pretty new. And it's one of the ways we distinguish ourselves, because again, when I look at a patient, I need to really look at all of what's going on in their life, because I can give them a prescription, but if they can't afford the prescription, then I really haven't done anything to help them achieve a better balance in health. If I don't address the fact that maybe they live in a food desert, or they're caring for elderly parents, then again, I may not be getting the best outcome for them because I failed to take into consideration their entire well-being. So a lot of folks think of osteopaths as people who just do manipulation, and we do believe that there's a significant impact that the musculoskeletal system has on bodily function. But that's not the only thing. DOs can specialize in any specialty that they want or can get into as far as residency programs at this point. And it's really doing the manipulation is just another adjunct therapy or treatment I can offer patients. And so I did my training as an internist, and I actually still did manipulation because that actually helped my patients get to better health, and quite often with lower doses of medication or even not needing additional medications. So let's go to the next slide. And this looks similar. But one of the things that we look at is this idea of structure and function being interrelated. And this is where we start talking about things, these new terms that you might not have heard of, particularly somatic dysfunction. This is how we indicate where there is a mechanical disruption in the body. And that could be at the level of a joint or at connective tissue or even at the cellular level. And then we also have a couple reflexes that are important. So we know that, or most people are familiar that when they have angina or there's insufficient blood flow to the heart creates some pain, and quite often you get chest pain or maybe left shoulder or both shoulders, and pain down the left arm as a response to that lack of oxygen. And that would be considered as viscerosomatic reflex. It also changes the orientation of the vertebra in the upper thoracic spine because of the neurological connections. By the same token, we also know that there is a somatovisceral reflex. So people who have scoliosis, and if it's of a significant degree, that can also impair cardiac and respiratory function. The word TART is an acronym standing for tissue texture abnormalities, asymmetry of position, restriction of motion, and tenderness, which could be any abnormal sensation. And these are the criteria for determining a somatic dysfunction in the body. The use of manipulation, in looking in the blue circle there on the bottom, is only one other thing besides using medications. We are taught how to prescribe medications. We hold DEA licenses as well. But we also look at partnering with our patients. And the World Health Organization actually recognized our 5 models of osteopathic medicine as something unique that we have offered to the world, because we are quite international at this point. And the way we approach people is through one of these models. I didn't include those just because I didn't want to get too much into the weeds here, but I'd be happy to talk about those if someone's interested.
Dr. Kania?
Yeah.
I have a question.
Sure.
About, and maybe you'll get into this, but could you tell us how osteopathic manipulation compares and contrasts with chiropractic manipulation?
Sure. The story goes that Dr. Palmer, who started the chiropractic movement, had also, or prior to that, had attended the osteopathic school for a few weeks and then left. So he actually trained under Dr. Still briefly. There's a lot of similarities. At this point, I'll just contrast things as best I know. I believe that an chiropractic program is about 3 years, and it's heavy on anatomy and physiology and their treatment techniques. Our curricula is very similar to that of a medical doctor or allopathic school. And we have, in addition, the manipulative treatment that we teach as well. Chiropractors are not allowed to prescribe medication, whereas we are. They have a number of different techniques that they can do, and most of what they consider treating is primarily the spine, from the top of the cervical end of the spine all the way down to the lumbar spine. We actually look at treating all parts of the body: the cranium, the spine, the organs, the extremities, the pelvis, sacrum. So there's a little bit more, a little broader scope there. Some of our techniques look very similar, and then we have a bunch more that I have not seen or heard of chiropractors using, but I will allow that may be my ignorance than anything true. So is that did you have another question?
You.
Okay.
No, that's great. Thank you.
All right. Let's have the next slide, please. Okay. So the somatic dysfunction ultimately is an impairment in function of any components that are related to the somatic system. So that's skeletal, so obviously the bones, the joints, but also the connective tissue, the myofascial structures. But it also affects blood vessels, the lymphatic vessels, the nerves themselves. And I should have put in also the organs. As an internist, I have to say my world just exploded exponentially when I learned how to manipulate organs, and quite often was able to get people off medication, and their bodies were able to return to a better level of health. So we do this, I don't look at it so much as decreasing pain. I really look at can we get people to better function? Because if you're more functional, you can tolerate aches and pains better. And pain is a really subjective situation. I mean, you know, the idea that someone one could end up with a heart attack just because your loved one, your spouse dies, is very well known in the medical world. Takotsubo syndrome, Subo syndrome, rather. And we've characterized why that is. We know and we understand it's an increased level of inflammation that affects the heart, and quite often people will die literally of a broken heart. Treatment, you know, we certainly can treat that medically, but you know, the question is that pain truly all physical, or is it really more emotional? And so for me to tell somebody I can decrease your pain is rather presumptuous. And early in my career, of course, I thought I could, and I did a lot of times, but I finally realized that I can't address all the reasons that people have pain. And so but I could maybe make them more functional. And, you know, when you can't move or do certain things, particularly things you enjoy, you start having less quality of life. And if I can improve one's ability to engage in things that they enjoy, then their quality of life goes up, and consequently, their tolerance for pain actually increases as well. And in fact, to the point where maybe their pain isn't nearly as noticeable. So I don't promise people that I can decrease pain. I'll let you go to the next slide, Michaela. Okay, so the goals for treatment is to remove those restrictive barriers and to allow our own self-healing and restore homeostasis to our bodies. Obviously, improve function, as I just said. All right, and next slide. Okay, so that was just kind of a really quick nutshell of osteopathic medicine. Does anybody have any questions related to that before I start moving off talking about Burrell? Okay, yes, Charlie.
Dr. Kania, do you have specialties within your DO like the MDs do? Or
Yes, we do. We do. I'm old enough to actually remember the time before residency. When I finished medical school, all one had to do is a year of postgraduate training. We called it an internship, and it was what we call a rotating internship. So I actually worked in all the various specialties. I had plans to become a family doctor delivering babies in a rural area. So I made sure I took a obstetrical rotation, and I've delivered about 30 kids. And I have to admit, it scared me the entire time. So I did not go that way and ended up being recruited into the internal medicine residency program. And so then I practiced as an internist for about 20 some years before I started limiting my practice just to manipulation. But we do have neurologists, neurosurgeons, orthopedic surgeons, ophthalmologists, dermatologists. You know, we're accepted into all the specialties at this point in time. We have osteopathic residencies, but at this point in the last couple of years, both the MD and the DO worlds have combined their residencies for a variety of reasons, mostly things. The push was by the federal government, who funds Medicare. Medicare funds residency training. And I think the reasoning for that was the combination was that osteopathic residencies were actually able to train residents for significantly less money than the allopathic world. And the idea was that somehow merging us would decrease the cost, and it might be a little short-sighted because there's far more medical allopathic residencies, and they kind of drive things that way. I'm sorry, was there another comment from somebody else?
Yeah, this is Dave Rice. I had a question. Just as I'm looking at the idea of the, trying to move the body back into a normal status, I'm thinking with cardiovascular disease, for example, at least a number of the treatments that I'm aware of deal with, for example, a narrowing of an artery or something, which is, you can say, yeah, if you'd have done the right thing with diet and various other things, you wouldn't have gotten here. But once you're there, the idea of sort of manipulating your way out of it strikes me as challenging. And then my other related to that is just the other big disease of the years or life is cancer, as again a cellular based system that goes awry, literally, that we normally get out the knives and remove it, kind of a thing.
And then it moves through a lot of poisons and radiation to whatever our knives didn't get. Exactly. All right, so let's talk about the cardiovascular system. One of the questions that I have is, why do we get plaque formation in certain areas, in certain parts of a blood vessel, or an artery in particular? It makes a lot of sense, and my apologies to anyone who doesn't want to know this degree of anatomy, but I'm going to talk about it anyway. When we look at the main artery, the left anterior descending artery that feeds the left side of the heart, that comes off at a 90-degree angle from the aorta. So when we've got blood flow coming out of the chambers of the heart going into the aorta, the first thing the heart is doing is feeding itself. So you're going from one direction, making a 90-degree turn, and that's going to cause some turbulence in the flow. So it makes sense that you would get maybe the deposition of cholesterol or some irritation that causes some inflammation at that junction and leads to the formation of a plaque. But if you look further down in that artery, quite often there will be other plaques and consequently narrowing of that artery. And it isn't necessarily where there's another vessel branching off from that main artery. So the question then is, why does it happen? And I have to think that there's something going on with obviously inflammation, which we're really looking at, but also looking at the fascial system, this connective tissue. There's a ton of connective tissue in our chest cavities there to support the great vessels and the lungs and the heart. And is it possible that maybe there's some additional traction on that artery that's now causing it to be eccentric and affecting the laminar blood flow that goes through that artery? It's conjecture. I don't know how I can prove this yet, but it's when I've talked with cardiologists about it, and they do recognize, yes, we do get plaque happening in other parts of the artery. Not sure why, other than, right now the primary model is the inflammatory model. But could there be another reason for it? And they find that very intriguing. But again, there's no way I can prove it. It makes a lot more sense when we look at somebody who has severe scoliosis that this might be part of the etiology. But let's go back to that inflammatory aspect of it. And also, this ties in with your question about cancer as well. If we look at inflammation in the body, the question is, what can manipulation do as far as inflammation is concerned? And I'm currently doing research with one of my colleagues who is very much interested in this. We know that the vagal nerve can actually modulate the inflammatory condition in rats. So we're currently working to see if we can prove that in humans as well. And his arm is, for the study, is using a device that causes stimulation of the vagal nerve. The osteopathic arm is actually doing a technique where we apply pressure at the base of the skull, doing what we call a suboccipital decompression. which is thought to actually increase parasympathetic activity. And what we're looking at is how does this in fact impact the immune system? We've done a couple study versions of this study, and we do know that it actually decreases cytokines, which are usually released when people are in a pro-inflammatory state. We also know that we get a increase in monocytes being released, and particularly a change in those monocytes to the kind that are actually less involved in treating inflammation, but more involved in surveillance. And so we're inferring that we can actually decrease inflammation in the body with stimulation of the vagal nerve and through osteopathic manipulation. So there's that would be more of a perhaps a metabolic or circulatory approach. If we also look at it from a biomechanical standpoint, if somebody is mechanically challenged, whether that be something in their feet or their pelvis or their lumbar thoracic spine, we know that there is an increase in about in the amount of energy that they need to exert just to maintain being upright in a gravitational field by about 300%. And so that effort has to come from somewhere. And that's a huge demand both on the heart and the metabolic system. So if I treat somebody and I can reduce the amount of workload that they are required to do for living, then I've actually offloaded the allostasis, and it's easier for them to get back into a homeostatic position. And we've actually seen this in our, and it's one of the reasons why we even look at cardiac rehab, because that's another way of improving the musculoskeletal system, increasing muscle strength, so that the muscles can actually work with less demand on the heart ultimately. Does that answer your questions, David?
Well, it responds to it. It seems to me as I'm hearing you describe the complexity of the situation, that your approach broadly here is one that says, okay, if you get a condition, say a heart problem or a muscular or a problem with a postural injury of some sort, that the methods can be used to reduce the likelihood of that disease progressing or maybe reverse them. But I was just looking at the situation where if a patient hasn't had the benefit of advice, manipulation, treatment, and then shows up with an advanced cardiovascular problem or something else, that sort of more drastic measures might be merited as opposed to manipulation. And that's what I was trying to understand.
Sure. All right. Let me give you one more example. Well, first of all, if somebody's coming in with chest pain, I am going to address that chest pain the same way an allopath is, because the important thing is the chest pain is there because the heart's complaining it's not getting enough oxygen because blood flow is being impaired. If I ignore standard of care, that person may not be around if I'm doing something that might be working at a slower pace. And so, of course, I'm going to do that. But the other thing is I can directly address the upper thoracic spine, which is where the sympathetic innervation of the heart muscle comes from. And by doing that, reducing the abnormal tension on those vertebrae is going to, wait a minute, if there's abnormal tension on those vertebrae, then we're going to end up with vasoconstriction because there'll be increased sympathetic tone. And that vasoconstriction to the heart is going to be feeding into that lack of oxygen, and consequently the chest pain. So if I can improve the proper relationship of the vertebra, I'm going to be taking away some of the tension on those sympathetic fibers, And the homeostatic mechanisms will actually then reverse the vasoconstriction, and so we get better blood flow. So it can be both acute as well as chronic. But again, my training, especially as an internist, is I'm going to be giving that person nitroglycerin and oxygen and getting the EKG and calling, the cardiologist to look at stenting them or bypass surgery, just like an allopathic physician would. It's more, what do we do after that? We also have some studies that have shown that not only by treating this, not only do we improve blood flow, but we also decrease the irritability of the heart, and we have fewer episodes of irregular heart rhythms when we do this.
Okay, thank you.
Sure.
That's helpful.
Oh, gosh. So I was told you guys were a sharp crowd. Okay. Any other questions?
Well, this is Jane Ash, and I would just like to comment on what you have just said, and particularly, doing the things that are helpful to keep people in a normal heart rhythm, because when the heart is in an abnormal rhythm, then it does damage to valves and all kinds of things in the heart. And just living with a person who has suffered with heart disease for many, many years, I can see what happens when stress sits in. And I can also see what happens when there's relief from stress. And I have come to believe that some of these osteopathic methods can make a huge difference without lots of invasive surgery at certain points. Obviously there sometimes comes a time when that's the only thing that's going to save a person. But this is all making just a whole lot of sense to me.
I look at osteopathy as being applied anatomy and physiology, and that's the way I approach it with my students. It's like, all right, the anatomy, the physiology. Let's now put this together and definitely look at some of the research. We don't have as much research into it as most of us would like. And it seems that when I look at where am I going in my career, at this point, the thing that really gets me excited is being involved in the research to prove that what we have read, that the reports that we have read from old-timers, old-time DOs, but also what I've observed in my own practice is actually very real phenomena and could be used to treat some of the problems that we're facing, where we've got either only very expensive or limited treatment. Allopathic medicine, and I'm not saying osteopathic medicine is the end all and be all, but then again, neither is allopathic medicine. And the question is really, how can we get people into better health and, meeting them wherever they may happen to be. And what I've found is the more functional I can make people, if their feet hurt because they've got some bones that are not in the right place, if I tell them they need to exercise more, but they've got a limitation, then I really haven't done anything for them. But if I can get their feet into a more functional positioning and they're able to go into start an exercise routine, not only are they going to have better cardiovascular health, but if they happen to have diabetes, they end up having better glycemic control because of it as well. And so it's really kind of looking at that big picture and seeing what more can we do for people.
I have a question. My name is Susan West. I was wondering if you could speak to whether DOs have a different view of rheumatoid arthritis, because from my experience, it is treated by medication. And I'm just wondering, do you have any, does DO look at it differently?
That's an interesting question. I remember getting asked this early in my career, and I didn't have an answer then. And I have to say, it's my colleague who's an MD PhD who's kind of pushing me into that realm, because he's interested in rheumatoid and inflammatory conditions because of family members that suffer with it. And we do know that people who have rheumatoid arthritis, if they stay physically active, they actually have less joint deformity over the long haul compared to those who are not physically active. We also know that that physical activity helps clear inflammation from the body better than our biologics, but yet we still are using those biologics or anti-inflammatory medications. And so we actually have a couple research projects that are going. The one we have currently is looking at that in the hopes that we can use it for something like rheumatoid arthritis, but we're still starting at a very basic level. I know that he is also looking at starting a study looking at psoriasis, and there is a form of arthritis that we call psoriatic arthritis that's associated with the skin manifestations. Not everybody who has psoriasis ends up with psoriatic arthritis. But again, there's a limitation in what the medications for that type of arthritis can do. And we're looking at, could there be something beneficial between vagal nerve stimulation and osteopathic manipulation? Sorry, I was going to sneeze. Okay. So there's a possibility, but I don't have any definitive answer for you, Susan.
Okay, thank you.
You're welcome. Okay. Any other questions?
Yeah, I have a question. Back 25, 30 years ago, I had a blockage in the back of my heart, and they put a stent in, and then I've been taking anti-cholesterol and statins, that sort of thing. And it's really worked out very well. And I had serious blockage in an artery in the back of my heart. So that seemed to, I'm going back 35 years. That seemed to have worked very well. I'm now 87 years old, still kicking.
Yeah, definitely there's a place for medication. I'm not going to say that we shouldn't be doing that. There was a study done, and probably about 30 years ago. At that time, we being medicine, was doing angiograms pretty much on anybody who had heart disease. And it was acceptable to do follow-up angiograms, even if they were not having chest pain at the time. Insurance companies limit us from doing that now, but what these cardiologists found was they had a group of patients, and of course they recommended a low-fat, low-sodium diet. And patients were allowed to self-select into their group. So there was, of course, the few that said, you know what, you can't take my bacon away. I'm going to continue that. There were some who went, okay, I don't want to see you again. I will follow the American Heart Association's diet. And then there were those who, you know what, I really don't ever want to see you again. I'm going to go vegan. And a year later, they were followed as best they could. 30 years ago, our guidelines for cholesterol levels were very different. But they repeated the angiograms, and what they found were those who stayed on the typical American diet that was high in fat and salt actually had a progression of the plaques in their arteries. They had a progression of disease. Those that stayed on the American Heart Association had very stable disease and did not have a progression of the plaques. Those that went vegan actually had a regression of the plaques. And so this idea that we don't need to eat as much meat as we think or have been led to believe might actually be wise. It's just hard to change our palates after all these years.
Yeah. Okay, thank you.
Sure. All right. Let's go to the next slide, please, Michaela. Okay, so this was taken out of the newspaper just a couple months ago. And clearly, we know there's a shortage of medical providers in New Mexico. And that was one of the main reason why Burrell College of Osteopathic Medicine was started down here, is to really help address this shortage. And this shortage is not just physicians and nurses, but pretty much every personnel that's related to the medical field here. Let's go to the next slide. So to start with, when David asked me to give this presentation, of course, I checked in with folks and, you know, just like, all right, what are we doing here? And we have a significant economic impact. And this is information from 2020, which is the most recent data I could get from the school. And certainly we have put in quite a bit of money into the local economy between payroll, vendor spending, construction spending. We're actually expanding the school at this point, as well as the spending that comes from having students in the area. And so the total amount of money spent, at least in 2020 alone, was about $50,000, or excuse me, $50 million. That 40 million in construction spending was since the beginning of the school, which has really been spread out over a number of years. Let's go to the next slide, please. Right now we have 172, current and future medical residents that we anticipate to be in the region. I've got more specific data about the residencies coming up on another slide. Residency programs are expensive, but they, we do get money from Medicare to come in, and that Medicare does go, those Medicare dollars do go to the hospitals. And so there's additional economic contribution because of the residency programs at both Memorial and Mountain View hospitals. Next slide. We have, we started working a couple years ago to do a very specific program to look at the disparity of providers, particularly for the Native populations, and had met with the Pueblo elders of the Pueblo of Acoma, looking at what we could do to help. Their program was actually slated to really begin quite earnestly last year, but with the COVID pandemic and the need for them to close the tribal lands to visitors and focus on that, we've put these programs on hold. Hopefully we'll be able to maybe reopen them next year. Next slide. Okay. One of the problems that we are facing at the school is having adequately prepared students locally to be matriculants. And it's because there needs to be better science education, but really we're looking at changing the perspective of folks and letting them know that, yes, they too could grow up and become physicians, and that if we look across the country, the predominance of medical students are white students, and minorities are really a fairly small percentage. Our school, I think we've gotten up to, I want to say the high 30% with our minorities. Unfortunately, when we look at things, there's only one other osteopathic school that's doing a little bit better than us, but it's an osteopathic school that's actually on tribal land in Oklahoma that has more minorities. Unfortunately, when we look at enrollment of Black students, that has decreased over the last few decades across the country. And there's a lot of reasons for that. So we've realized that we really need to focus on kids in school, grade school, middle school, as well as high school and college, but really starting young to plant that seed that they could grow up to become a doctor. And so we actually have a number of different programs in place where our medical students are paired up with students, acting as mentors and just introducing them to some of the things. And, you know, in some ways, it looks like it's rather simplistic, but again, just introducing people to this, you know, to increase their awareness of what's involved and take it out of the realm of television, because, you know, on television, everybody gets better. And there's all kinds of things. And I have, I had to deal with it with my own parents because they thought, oh, but you guys can save me. And it's like, it doesn't mean you get to keep destroying your body in the process. Yeah, I don't know if you want what we really can do. And so we're trying to maybe normalize some of what we're doing. They get to come, pre-pandemic, we had them coming to the school. They learned how to do some suturing. They got to play with the mannequins we have that we use for training. Give them a demonstration of osteopathic manipulative treatment. And certainly as, you know, talking to both the high school students and also there's some that are in college at NMSU, actually talking to them about how to go through the interview process. My first interview to medical school was just really embarrassingly awful, but I was only 15 at the time. And it just was really, I was out of my element big time and I didn't interview well and I could tell it wasn't going well. And I actually interrupted the interview and said, look, let's face it, I'm 15, I am not ready for this. And what I really needed to do is learn how to interview. And we don't think of that as being a skill, but yet it is a skill. And it's something that can be taught. And if you don't have anyone in the family who has gone on to into medical school or something that requires a lot of interviewing process and learning how to sell yourself, then you're not really ideally equipped to even make it through the process of getting into medical school. And I was a first generation college student in my family, and so I had to trailblaze. And so this is really important to look at. These are the skills that our students need. I should say our children need, not just our students. And we also have a similar program for our students to teach them how to interview with a residency interview, because that's just another level of training that they need to receive. Let's go to the next slide. Is Michaela still with us? Oops, I think you missed one. There we go. Nope, go back. And go back one more. There we go. So another thing that we do is a doctor of osteopathic medicine for a day, so DO for a day. And this is where we're looking specifically at undergraduate students. Prior to the pandemic, students were invited to come to the campus and actually sit in on our lectures and tour the campus, just so they had an idea of what medical school looked like, specifically what does an osteopathic medical school look like. Last year, because of the pandemic, we switched to a virtual event and had over 60 participants from a variety of universities and colleges across the country. We do make a specific push for students in this area, the El Paso, Las Cruces, Tucson area, looking at those borderlands, because again, most physicians end up practicing near where they went to school or did their residency or close to family. And so consequently, that's why we're here. I'm the anomaly because I grew up in Michigan and moved to Colorado and now in New Mexico. All right, let's go to the next slide. Okay, we have a specific program at NMSU where it's a bit of a pipeline. And this, again, we're trying to, because NMSU draws students from the state, and particularly in this area or in our catchment area, we're really trying to pair them up with medical students and hopefully streamline the application process so that they can get automatic acceptance into Burrell. The actual application process is incredibly stressful and incredibly expensive. One of the benefits perhaps out of the pandemic was the fact that I believe all schools now offer a virtual interview process, and that just cuts down the cost. I mean, there's a significant cost just applying into the program that we use, that all colleges use for applicants. And for each college you select, you pay an additional fee. And so at least we're saving the students the travel funds that are involved typically, as well as lost wages a lot of times. So by doing this program with NMSU, we actually have a pipeline, and if they maintain a certain GPA, and I don't know what that GPA is, they are guaranteed, they have a high probability of acceptance. We do have a final decision that is made by the college, because it's not just about academics, it's also about whether that person is suitable for becoming a physician. And so we look at other things, you know, mainly can they even talk to a human being appropriately? You know, do they have the interpersonal skills to be a physician, which is, I think, the main reason why we do interviews, as besides just looking at applications. Okay, next slide. Our students have done a lot of community service. We've had, I can't even tell you how many health fairs. With the pandemic, there was a number of different drives to collect protective equipment and donate that to healthcare workers, as well as to the various tribes in the state. We have had clothing drives multiple times. Quite often this time of year, we're collecting coats for children. We had a huge clothing drive when the border crisis with the immigrants happened about 3 years ago, and then again most recently with the Afghani refugees. Baby blanket drives. We have a group, Seeing Limites, with students pairing up again with kids in elementary school, just to keep them in school. We were stunned when we found out that most children make their decision to drop out of school in 5th grade. I have a grandson who's in 4th grade, and the idea that in 5th grade he's going to decide he's not going to go to school just blew my mind. And so this is one of the ways we're trying to help the community. We've had a number of various programs, obviously around the holidays, to do a lot of drives. And then if you go to the next slide, because the community service actually didn't all fit on one slide here. Okay, there, thank you. We've also did actually a lot of the students helped quite a bit with both testing for COVID as well as doing vaccine distributions, not just here, but across the country and in Tucson as well. We've had God knows how many blood drives, which, you know, on campus, which I think is wonderful because it's just easy to go down and donate when it's at your work site. Booted the flu vaccination, that was something done again pre-pandemic. We are still working with the soup kitchen, collecting glasses, used glass, you know, eyeglasses for distribution to those who have none. And then one of our students just last year was looking at doing getting wheelchairs for people. in the El Paso community and set up a GoFundMe and ended up getting, I think, twice as much as what he was hoping to get. So rather successful fundraising there. Next slide, please. A lot of outreach, working with NMSU's wellness program, particularly looking at alcohol and violence education. The Texas two-step CPR learning event was one of our earliest ones. And just to teach people how to do CPR and how easy it is. In fact, the number of people who participated, this was a national event with a lot of different medical schools, and Burrell was number 2 in the country for the number of participants that it had, which was really quite exciting for us that we were able to reach that many people. We've done, the students actually hosted Narcan training for community members in collaboration with the Department of Health, as well as obviously, the other things listed here. Next slide. Still, again, a lot of educational aspects here of trying to introduce people to osteopathic medicine and to let people, students know that going into medicine is something that they can do. Because we were not able to work with the Pueblo directly, students actually created an outreach video for the high school students. So actually the Jemez Pueblo, looking at a way of, again, giving them the idea that they could go into STEM careers. Next slide. We have a nonprofit organization, the Southwest Foundation for Osteopathic Education and Research. And just in the past year, we awarded over $800,000 to students and to not just for scholarships, but also for student research. Next slide. So now the real thing we wanted to know is, what are we doing specifically for that lack of or the dearth of healthcare providers here in the state? So we graduated our first class last year. We had a match day that always occurs in March around the 20th there. And we actually placed over 100, or we placed 100% of our graduates on that day. That's an incredible feat especially for a brand new medical school. And the most amazing thing was some of the places that we ended up having students matched, quite notable institutions at very prestigious residencies. So we're really tickled about that. Of those 133 graduates, 42 of those doctors are in New Mexico, Arizona, or Texas in their residencies, with a breakdown of most of them in what we would consider primary care fields. The other students were spread out among different residencies. And so I don't remember who asked the question. Was it you, Charlie, who asked about whether we could be, we could specialize in other things? And this is evidence that not only can we specialize, but our students are specializing as well into these other areas. And I have to tell you, again, these are incredibly, some of the places they went, I was blown away. These were incredibly competitive residencies, and they were able to get spots there, and we were quite tickled. Physical medicine and rehab, I think there are only 3 or 6 residencies in the entire country, and we placed several students into that specialty. And so, just amazed me on that. Anesthesias and orthopedics are also incredibly competitive, and just wonderful to see our students getting into that as well. If we go to the next slide. So we did have a match again in March of this year, and we again have more students in residencies, and I think actually it might be the final slide that has the totals there. What we do know, though, is people who do their residencies, about a third of them will stick around in the general vicinity of where their residency is located. And so our push is not only to have the medical school, but obviously, but we're also really putting a very concerted effort into having residency programs here. But to go along with that, in order to train students, they also need to have clinical sites in their clinical years 3 and 4. And we have multiple hubs, one out in Roswell, another one out in the Four Corners region. And we're really looking to promote getting people into the rural areas because that is where there's a huge need. Now, part of this is not just training people and giving them those exposures. Part of this also requires perhaps a change in the way we fund healthcare in this country. It's hard to attract people to come to a state where there isn't a lot of insurance coverage. And if you have a lot of Medicaid or Medicare populations, those are clearly underserved, and it's primarily because the reimbursement is significantly less than what one would get from a insurance company. And that really, that part of our shortage is really related to the fact that the way we fund healthcare in this country is skewed toward money-making schemes. And I don't want to get on that soapbox, although I can easily do that. Let's go to the next slide. Okay, I guess that was my last slide, but we clearly have placed a lot more students who are now residents, so young doctors, into training in this area, with the idea that a third of them hopefully will stay in this area, and that ultimately we will see some improvement. A lot of the residencies are 3 or 4 years, and so we're not, we're still young in this process, and so we're not going to see the full fruits of our labor for a few more years. Any questions at this point?
Yeah, I just
Thank you,
wanted to-
Michaela. Excuse me, just 1 second. Michaela, could you take the PowerPoint down so we can have the gallery? Thank you. Go ahead, Paul.
Yeah, I know one of the problems that when students get done with their 4 year of medical school, they have a tremendous amount of debt, and anywhere from $150,000 to $250,000.
Oh, that's low.
What's that?
That is low. That is
Is that right?
Our tuition is considered the middle of the road, and we're looking at about a little over 60 grand a year. So they're coming in debt at 240,000. And then it ends up getting compounded. So to be honest, that alone, the only reason why kids go into medical school is they don't really quite understand the amount of debt they're going to accrue. And once they get into residency and all of a sudden those loan notes start coming due, that's when they start going, OMG, what did I do to myself? And it's also a reason why it's very hard to get people to go into primary care, family practice or pediatrics, because the reimbursement, particularly in those areas, is significantly lower than any of the surgical specialties. And so the idea of getting people to stay in primary care is a challenge across the country.
But
as
also
well.
rural areas too, because
Right. And if you don't have health insurance to pick up, how does the doctor get paid? When you've got to pay, and there, my students who have graduated and are done with their problems, they're telling me that their loan payments are $3,000–4,000 a month. I mean, that's more than a house payment.
Yeah, we happen to have 2 doctors in our family, but they graduated back in the early 80s, and that was a lot different. And
Absolutely.
they specialized in a couple different, but today it's just terrible.
Oh, my total debt for medical school, now I had saved up enough to pay for the first year of school, but my total debt was only $47,500, which
Yeah,
I
my
wouldn't
our
really
daughter,
do.
same thing, and she got federal loans at about 1% at that time. You don't have any of that available
Oh
today.
no, my loans were 8-9%, and so and fortunately I had the ability to do moonlighting, which is really difficult for students or for residents to do now. And I was able to work additional places just to bring in extra money to start paying my loans early. So yeah, I mean, the whole
That is a big problem. It is a huge problem.
exactly. I mean, the idea of that students, need to go into so much debt just to provide health care to society, I think it's unconscionable. And the irony is that the UK, where they weren't paying, is now instituted, I think it's now $5,000 a year or maybe a term for medical school, but it's like, holy smokes, 5,000, that would be nice. But, but the fact that other countries are able to offer training at no cost to the individual. All right, I'll stop now. Sorry.
Okay.
Dave Rice, do you have your hand up?
Yeah, I just had a question with regard to your goals that you'd mentioned. It looks like that your recent experience with number of graduates is about maybe 130 to 150 a year. Is that your built out estimate, or do you hope to be greater than that in the future?
So with we accept, we're currently authorized to have 150 students per year, and we're allowed an 8% overage because there's some attrition that occurs. We accept a student and for whatever reason, either they can't hack it academically, or they have health issues, or they come to the realization that this isn't really for them. So we take usually 162 students. To have 133 graduates is not bad for a brand new school. When I started in another school, same thing, we had 162 students, but we graduated, I think, 122. So that's pretty much the norm. Ultimately, we would like to see closer to 150 surviving the process.
Yeah.
We are looking to expand the student body, and that's something that's going to get decided a little bit later this month. There is the Commission of Osteopathic College Association. I think that's their acronym is COCA, and the COCA will have a meeting this month. We've petitioned that we be allowed to increase our class size, and we would go from 150 students to 200 students. And that's going to be a challenge just to pull that one off, but nothing stands still.
Okay, thank you.
Okay, we're getting close to, well, we're a little bit over time, but I just want to, I have a question, but I want to make sure that there are no other questions that are out there, and don't be shy. If you've got one, I'll hold mine for Jane.
Dear, I wanted to ask just very quickly, do you get any money from the Kellogg Foundation?
Not that I know of, but that might just be my ignorance, Jane.
Well, I was just curious because this is one of the 3 states that they invest in heavily, and healthy families is a high priority for them. So, probably your finance people look at all those things, but it would be such a logical source.
Okay, well, I'll look into it and pass it on to somebody if it doesn't, fit my, specific needs. I'm always looking for new areas for grant funding, because, that's how research happens, right?
Right.
We have gotten some grants into the school for my, through me and my colleague. I'm also mentoring a group of residents at Mountain View, and they received a grant so from the American Osteopathic Association. So, we're definitely interested in those things.
Mm-hmm.
Okay. My question is this, and that is that if you, osteopathic physicians and allopathic physicians, their practices are virtually indistinguishable, with the exception of the added arrow in the quiver of the osteopath, of the osteopathic manipulative therapy. My question is after an osteopathic physician has gone through a allopathic residency, which most of them do, and you look out further into their practice lives, what percentage maintain their skills and continue to practice osteopathic manipulative medicine?
And there's the rub, and this is the sad thing, because we, when I went through school, I was required, all of my classmates and I were required to actually do a month of manipulation in somebody's office. So that it became part and parcel to the way we approach things. As fewer doctors practice the manipulation, that becomes, that was impossible to maintain. We just don't have enough providers. Right now, I think it's as dismal as 10% of DOs actually do manipulation. Now, I would like to, and so if you don't see it done in your 3rd or 4th year of medical school, and if you don't do it in your residency, it's really hard to pick up that skill again. And even though I did do that osteopathic rotation, and I did an osteopathic residency, I can honestly say that I did not see my attending physicians do manipulation, but they did encourage me to do it. But I will admit I'm the anomaly. One of the things that we do differently at Burrell is the way we've structured our instruction is our assessment of our instruction is we actually have true competency testing. So the students have to examine one of their colleagues, and they have to be able to make a diagnosis and then provide a treatment that resolves the problem by at least 50%. And they have to do this both in the 1st year as well as the 2nd year. And I'd like to think that this true competency testing, because it's, the students are like, well, where's the checklist of what you're going to grade me on? And I'm like, here it is. It's this simple. You have to make an accurate diagnosis. If you don't make an accurate diagnosis, you cannot provide treatment. We're not going to supply that diagnosis. And so they have to actually get good at making diagnoses. They end up learning 5 or 6 different ways to treat the somatic dysfunctions, some with the more familiar methods, and then some with what we call indirect gentle methods. And, there's something really gratifying when you're done, they finish their list, and I reach over and I shake their hand and say, congratulations, you're competent. It changes their demeanor because, rarely are we ever told we're competent, right? Certainly not in medical school. But when you hear this, like, I'm competent, I can do this. It's like, yes, you can. And then, they go home for the holidays and they start treating family, because family is like, well, what is this DO stuff? And they start treating them, and they come back. I just had a bunch this past week because they came back from Thanksgiving, and they're like, Dr. Kania, I did this for my mom or my dad, and it worked. And they were just so thrilled to be able to see this. And they said, and of course they mentioned it to so-and-so. And then all of a sudden I had like my cousins lining up to get treated. I just hope that translates further down. Only time will tell, and that's the hard part. We do have postgraduate courses. Not all of the skills that I can do can be taught to medical students. You need to have, in fact, the way we designed our education, the first month and a half is really all about learning how to palpate. What do tissues feel like? Because if we didn't do that, they really couldn't handle the more advanced things of how do you make a diagnosis of a vertebrae being rotated abnormally. And so it's really quite, you know, I have to say it's been fascinating to learn how to teach it. But yeah, the question is, will they continue? And I honestly don't know about that, sadly.
Can we get a
Well,
copy
thank
of
you
the
very
slides, Dave? Dave, would you
Absolutely.
get-
I
Yeah,
did.
I'll be happy to supply those.
Right, a
If anybody
copy.
wants them, send me an email and
Okay.
I will forward them to you. Okay, a
Okay.
big round of applause for our guests.
Thank you.
Thank you
Thank
very,
you for
very
spending your
much.
Sunday afternoon with me, folks.
Okay.
Well,
Well,
I
our
just wanna-
pleasure.
I just want to make a comment. I see a lot of your students at the doctor's office I go to here in town, so it's great to see them.
Oh, good. Yeah.
Yeah.
You know, I used to teach
I
up
do
in
too.
Colorado, and as the students started going out, in particularly in the Colorado Springs area where I was, I'd end up with patients going, "Hey, I saw one of your students, and now that I'm down here, I usually get those patients sending me messages on Facebook. I'm still seeing students of yours or now graduates, so it's really kind of fun."
Okay, a quick announcement about next week. Our speaker next week is going to be Jessica Johnson, who is the Legislative Executive Director for Animal Protection Voters in New Mexico. She actually had a editorial in the editorial section of the Las Cruces Sun-Times today about passing Roxy's law banning the
That was a good article.
regulating the use of lethal traps and poisons on public lands. So look forward to seeing you all next week at 2 o'clock, same place. Look for Sherry's announcement of Zoom. And again, thank you, Dr. Kania, and so long, everybody.
All right. Bye-bye, everybody.
Bye.